Karsten Dahman, and I'm a fourth-year medical student at Creighton University. Today I'll be talking about leptomeningeal metastasis, presentation, and workup. I wanted to start by just showing a full slide of my entire poster presentation, but because of the format and due to convenience sake, I will be breaking it down into individual PowerPoint slides so that it is easier to see all the text and the images larger. Like I said, I will be talking about leptomeningeal metastasis, the presentation, and workup. I would also like to thank Dr. Buragata and Dr. Mirza for their help. Introduction. Tumor involvement in the arachnoid and pia mater is known as leptomeningeal metastasis, and is most commonly a complication of advanced stage underlying cancer. While an uncommon diagnosis, even in patients with metastatic cancer, approximately 5%, it is most commonly seen in relation to primary brain tumors and solid tumors such as breast, lung, and melanoma. These are listed from highest prevalence to decreasing prevalence. Presenting clinical symptoms depend on the location of the metastases, but are commonly manifested as neurological dysfunctions. The most common presenting symptoms are radicular discomfort and pain, headache, mental status abnormalities, weakness, and/or seizures. Diagnosis is done through imaging and CSF studies along with the clinical presentation. MRI CT scan demonstrates linear nodular enhancement along the spinal cord or cauda equina. Seen in figure 1 here, an example of linear enhancement and some nodular enhancement as well. CSF analysis commonly shows elevated leukocytes, elevated protein, and decreased glucose. Our case, the presentation. A 64-year-old man presented to the ED due to 2 weeks of increasing dizziness, back pain, and lower extremity weakness that culminated in a fall and him being unable to get back up. While in the emergency department, stroke protocol was performed and was negative. Also at this time, all other labs were within normal limits. He reported no history of bowel or bladder incontinence. On physical exam, it was unremarkable except for bilateral lower extremity weakness when lifting his legs against gravity and band-like pain over the lumbar region of his back. Initial MRI of the lumbar spine showed diffuse enhancement along the distal conus and cauda equina with areas of nodular and thick enhancement. At this time, the patient was admitted to our hospital floor due to the concern of leptomeningeal metastasis, where a further workup was performed. The further workup included an MRI of the cervical and thoracic spine, which showed a posterior extramedullary soft tissue mass at T10 to T11 and focal areas of dural nodular thickening and enhancement throughout the thoracic spine. This is shown in the image in figure 2. T10 to T11 mass and seen on this image as well. CT of the lumbar spine was also performed, and it showed innumerable small nodules along the cauda equina and conus medullaris, the largest of which measuring 3 millimeters in diameter. You can see in figure 3 the innumerable nodular enhancements. This right here is the largest at 3 millimeters in diameter. CSF findings are also shown in table 1, and they showed the patient had an elevated red blood cell count, elevated total nucleated cells with a lymphocyte predominance, elevated protein, and glucose that was on the lower end of the normal limit. The CSF was also sent out for cytologic analysis. Discussion. This case illustrates the possible presenting symptoms of the rare disease leptomeningeal metastasis, and although this disease is typically a late-stage finding of metastatic cancer, the neurological symptoms associated with it may be the first sign of an underlying malignancy, which is the possibility seen in our case. The diagnostic approach for leptomeningeal metastasis should include imaging, such as MRI or CT scan, both of which were done in our case, and analysis of the CSF. Thank you for listening to my presentation.